Greater trochanteric pain syndrome, or GTPS, is a common and often misunderstood cause of pain on the outside of the hip. Affecting mostly middle-aged women, GTPS is characterized by persistent discomfort that can interfere with sleep, work, and daily activities. Historically, it was thought to be caused mainly by inflammation of the trochanteric bursa, but recent research highlights that gluteal tendinopathy, damage or tears in the gluteus medius and minimus tendons, is usually the main culprit. Understanding GTPS is crucial, as it impacts up to a quarter of people in industrialized societies and can lead to chronic pain if not managed properly. GTPS is most commonly seen in women between their 40s and 60s, with women being 3 to 4 times more likely to develop it than men. The condition is also more prevalent in people who have other musculoskeletal issues, such as knee osteoarthritis or low back pain. Many patients referred to spine specialists for back pain are later found to have undiagnosed GTPS. The pain can last for years, and those affected are at a higher risk of developing hip osteoarthritis compared to those without symptoms. Understand GTPS, it helps to know a bit about hip anatomy. The greater trochanter is a bony prominence on the side of the hip, serving as the attachment point for several important muscles and tendons. The gluteus medius and minimus muscles, sometimes called the rotator cuff of the hip, are responsible for stabilizing and moving the hip joint. Overlying these muscles is the iliotibial band, which acts as a tension band to resist strain. Multiple bursae or fluid-filled sacs cushion the area and reduce friction, but can become inflamed with overuse or injury. TPS typically presents as chronic pain on the outside of the hip or buttock. The pain often worsens when lying on the affected side, standing for long periods, or during activities like climbing stairs or running. In some cases, the pain radiates down the thigh but rarely goes below the knee. The discomfort can be severe enough to disrupt sleep and daily routines, making early recognition and management essential for maintaining quality of life. Diagnosing GTPS starts with a thorough clinical examination. Doctors use a combination of tests to pinpoint the source of pain. The most reliable are the greater trochanter palpation test, where direct pressure is applied to the area, and the resisted hip abduction test, which check for pain when the patient pushes their leg outward against resistance. Other tests, like the FABR test and single leg stance, can help confirm the diagnosis when used together. These tests are interpreted in the context of a full clinical evaluation to ensure accuracy. Not all hip pain is GTPS. Doctors must rule out other causes, such as labral tears, femoroacetabular impingement, or nerve issues like lumbar radiculopathy. Sometimes conditions like snapping hip syndrome or complications after hip replacement surgery can mimic GTPS. A careful assessment helps distinguish GTPS from these other problems, ensuring patients receive the right treatment for their specific condition. Radiographs, or X-rays, are often the first imaging test performed to rule out other hip problems like osteoarthritis or fractures. While X-rays can show bony changes or calcifications, they are not very reliable for diagnosing GTPS itself. Their main role is to exclude other conditions that might be causing hip pain. Ultrasound is a key tool for diagnosing GTPS. It can detect tendon tears, bursitis, and degenerative changes in the gluteal tendons. Ultrasound is highly sensitive and allows real-time visualization of the affected area. It's also useful for guiding injections and other procedures, increasing their accuracy and effectiveness. However, the quality of ultrasound results depends on the skill of the operator. MRI is another valuable imaging tool, especially for complex or unclear cases. It provides detailed images of the gluteal tendons, muscles, and bursae, helping to identify partial or full-thickness tears, muscle atrophy, and other changes. MRI is particularly useful when ultrasound findings are inconclusive or when surgical planning is needed. Ultrasound guidance is now the gold standard for performing injections and other interventions in GTPS. By visualizing the needle in real time, clinicians can precisely target the affected tendons or bursae, improving the accuracy and safety of the procedure. This approach leads to better outcomes and reduces the risk of complications compared to traditional landmark-guided techniques. Most cases of GTPS can be managed without surgery, especially in the early stages. Conservative treatments focus on reducing pain, improving function, and preventing further injury. These include lifestyle modifications, physical therapy, and targeted exercises. The goal is to relieve symptoms while promoting healing and restoring normal hip function. Simple changes in daily habits can make a big difference for people with GTPS. Reducing weight-bearing activities, avoiding positions that compress the hip, and using supportive devices like donut-shaped pads for sleeping can help. Patients are encouraged to avoid crossing their legs, standing on one leg, or walking on uneven surfaces. Weight loss, when appropriate, can also reduce stress on the hip and improve symptoms. Physical therapy is a cornerstone of GTPS management. Therapists design individualized exercise programs to strengthen the gluteal muscles, improve hip stability, and reduce pain. Resistance exercises, isometric and isotonic routines, and stretching are all beneficial. Education on proper movement and load management is also crucial, as it helps patients avoid activities that might worsen their symptoms. Some studies have explored the use of foot orthoses, special shoe inserts, to help manage GTPS. While these devices can alter walking mechanics and potentially reduce hip pain, the evidence is mixed. Prefabricated orthoses may not provide immediate pain relief or significant changes in gait, but they could be considered as part of a broader treatment plan for select patients. Extracorporeal shockwave therapy, or ESWT, is a non-invasive treatment that uses sound waves to stimulate healing in the gluteal tendons. High-quality studies show that ESWT can provide significant long-term pain relief, especially for moderate cases of tendinopathy. However, its effectiveness for more severe tendon tears is less clear, and standardized treatment protocols are still being developed. Corticosteroid injections are commonly used for short-term pain relief in GTPS. They can be effective for mild to moderate tendinopathy, especially in the early stages. However, their benefits tend to diminish after a few months, and repeated injections may carry risks such as tendon damage or tissue degeneration. Injections are best performed under ultrasound guidance for maximum precision. Platelet-rich plasma, or PRP, is an emerging therapy for GTPS. PRP involves injecting a concentrated solution of the patient's own platelets into the affected tendon to promote healing. Studies show that PRP can provide longer-lasting pain relief and functional improvement, even in cases where other treatments have failed. PRP is especially promising for higher-grade tendinopathy and is usually administered under ultrasound guidance. Hyaluronic acid injections are another option for patients who cannot tolerate corticosteroids, such as those with diabetes. These injections can provide pain relief and improved function, with some studies suggesting they are as effective as corticosteroids in the short term. Hyaluronic acid may be considered when other treatments are unsuccessful or contraindicated. Dry needling and percutaneous needle tenotomy are minimally invasive procedures used to stimulate healing in chronic tendinopathy. By inserting fine needles into the affected tendon, these techniques increase blood flow and promote tissue repair. Dry needling can be combined with PRP or performed alone, and studies show it can be as effective as corticosteroid injections for some patients. Autologous tenocyte injection, or ATI, is a new cell therapy showing promise for chronic gluteal tendinopathy. ATI involves injecting a patient's own tendon cells into the damaged area to promote regeneration. Early studies report clinical improvement and pain reduction, especially in patients who have not responded to other treatments. However, more research is needed to confirm its long-term effectiveness. Selecting the best treatment for GTPS depends on the severity of the condition, patient preferences, and response to previous therapies. Early-stage tendinopathy often responds well to physical therapy and lifestyle changes. More persistent or severe cases may require interventional procedures like ESWT, PRP, or injections. A stepwise, individualized approach ensures the best outcomes for each patient. Ultrasound guidance is recommended for all interventional procedures in GTPS. It allows clinicians to visualize the exact location of tendons, bursae, and needles, ensuring treatments are delivered precisely where needed. This approach improves outcomes, reduces complications, and is now considered the standard of care for injections and other minimally invasive treatments. GTPS is often a chronic relapsing condition that requires ongoing management. Patients may need to adjust their activities, continue home exercises, and periodically revisit their treatment plan. Regular follow-up with healthcare providers helps monitor progress and make timely adjustments to therapy, ensuring the best possible quality of life. Despite advances in diagnosis and treatment, there are still gaps in our understanding of GTPS. More research is needed to standardize treatment protocols, especially for severe tendon tears and emerging therapies like ATI. Comparative studies between different interventions such as ESWT and PRP will help clarify which options work best for specific patient groups. Educating patients about GTPS is a key part of successful management. Understanding the nature of the condition, the importance of adherence to therapy, and the role of lifestyle modifications empowers patients to take an active role in their recovery. Clear communication between patients and healthcare providers ensures that expectations are realistic and that treatment goals are aligned. Multimodal, individualized approach is most effective for managing GTPS. Combining physical therapy, lifestyle changes, and interventional procedures as needed allows for tailored care that addresses each patient's unique needs. This strategy maximizes the chances of long-term symptom relief and functional improvement. Recap: GTPS is a common cause of lateral hip pain, especially in middle-aged women. Accurate diagnosis relies on clinical examination and imaging, with ultrasound being the preferred tool. Non-surgical treatments, including physical therapy, ESWT, and PRP, offer effective options for most patients. Ultrasound-guided procedures improve precision, and emerging therapies like ATI show promise for the future. Looking ahead, ongoing research will continue to refine our understanding of GTPS and its management. Standardizing treatment protocols, exploring new therapies, and conducting high-quality comparative studies will help improve outcomes for patients. Collaboration between researchers, clinicians, and patients is essential to drive progress in this field. GTPS can be a challenging and persistent condition, but with early diagnosis and a personalized, stepwise approach, most patients can achieve significant relief and return to their normal activities. Staying informed, working closely with healthcare providers, and maintaining a proactive attitude are key to managing GTPS successfully. Conclusion: Greater trochanteric pain syndrome is a multifactorial, often chronic condition that requires a comprehensive and individualized management strategy. Advances in diagnostic imaging and non-surgical treatments have greatly improved patient outcomes. As research continues, the future holds promise for even more effective therapies and standardized care pathways for those living with GTPS.